To Dr. Osama. Bismillahirrahmanirrahim, and thank you, Dr. Osama. And thank you, everybody, for coming here and on Sunday. This is a very important topic and rarely been discussed elsewhere. We've been discussing about hypogonadism, infertility in last several conferences of PES, and this is the first time mention of number for piloting and important topic for discussion. We have three presentations today, and I'm going to discuss basically the workup evaluation. Patana Kamzori or erectile dysfunction is quite a common problem, most uncommon, but as a clinician, forget this important question in the history. As a result, most of the patients do not get satisfied. So the presentation layout would be the epidemiology, especially related to Pakistan and association of ED with cardiovascular disease. That's another important topic, and some key points regarding the causes, etiology, and circumstance, followed by test. And I'm going to start from the overview on this. And actual management, medical management would be discussed by Dr. Qasim. Psychological management would be discussed by Dr. Bahar. So, by definition, is a persistent inability to attain or maintain interaction. Not only this ED is or erectile dysfunction is not a medical issue, but it has been clearly documented that it not only represents a complication of cardiovascular disease, but sometimes early ED can be a sign of a forthcoming CVD itself. So, various meta-analyses and studies have shown that it is now a cardiovascular risk factor, considering the risk equivalent to a current moderate level of smoking. It's around 1.46 increased risk of CVD seen with early CVD. This was the famous study that was done in 1994 regarding the prevalence of CVD. You can see over the divided into three parts, and as that age advances, you can see the level of erectile dysfunction increasing. And this is not only seen in West, but also seen in our own patients as well. This was the study that was done way before, nearly 20 years back, rising around more than 1,000 patients, and you can see around 1/3 of the patients had reported erectile dysfunction in a general OPD clinic. Most of our patients do not seek any medical advice, but majority of the patients, almost half of the patients, consulted actually the quacks. The teams, homeopathics, they are famous for the treatment of Madana Kamzori. You can all see various slides, various banners being placed on various walls, roads, Africa. You can see Madana Kamzori ka lot. But 1/3 of the patients do report blockage. So, as a physician, you should know how to manage, how to work up for ED, and what are the management plans for it. Not only psychological aspect of ED are important, but you can see organic causes that are related to ED are very, very important. In this study, comprising of 434 patients who had ED, basically, almost half of the patients had cardiovascular elements, that is hypertension and diabetes. Diabetes, you can all know, very, very important cause of ED. In this case, 37%, almost 1/3 of the patients had ED. It's very common in depression. Dr. Wahab will discuss this disorder in depression. It's very, very common. This is another study that was published nearly more or less 18 years back in Pakistan. And you can see almost most of the patients who presented with sexual dysfunction had depression somewhere, or anxiety or depression or stresses as a cause of erectile dysfunction. This trial would actually meta-analysis of erectile dysfunction and risk of cardiovascular disease, and all-cause mortality in the general population. It was a meta-analysis of both studies and comprising of more than 1 lakh patients. They have described that ED is one of the causes of cardiovascular morbidity and mortality, but the data needs further confirmation. You can see over here, this is a box plot. You can see box plot, and some of the studies point towards more chance of cardiovascular morbidity and mortality with ED versus some of the studies. But overall, you can see the risk is slightly higher compared to a general population who do not have ED. The confidence interval are crossing one above. Risk is more or less the hazard ratio. You can see overall of these all studies were around 1.24. So, if you come on the possible types, basically, it can be a primary erectile dysfunction or a secondary. Primary is the man who's never been able to attain or sustain erection. It's very rare, and usually the psychological aspect is the most common cause, especially guilt, fear, and depression. So a detailed history is very essential to diagnose a primary AD, also always not common. Secondary one is more common. Patients have a normal erection in the past, but now is unable to do it. See the cause of basically erectile dysfunction. The causes are is a long list, and it's one of the I brought this slide from one of the presentations who have actually divided the word impotence into different types. You can see I for prostatitis, urethritis is one of the cause of PD, mechanical coronary disease, psychological for the P, depression, performance anxiety, relationship issues, stresses of various kinds, and for O, oculosis, vascular. Vascular is another very, very important. We see almost daily in our clinics, especially for hypertension, for diabetes, peripheral vascular disease, hyperlipidemia, venous diseases. Trauma is another important cause, although rarely seen. Endocrine, we do see endocrine cases in our clinic, especially hypogonadism and hyperprolactinemia. Neurological is one of the important causes, tend to forget, but this is an important aspect, especially in Parkinson's patients, MS, and patients who have spinal disorders. Drugs, chemical, and other factors are another important aspect. Drugs, especially a lot of anti-hypertensive drugs, especially we all know about beta blockers, which have been commonly prescribed by cardiologists for cardiac disorders. Several antidepressants, anti-anxiety drugs, which tend to increase prolactin levels and tend to cause hypogonadism and ED. Some other factors also involved, like old age, kidney disease as well. So this word impotence can be remembered easily, and the causes of ED can be highlighted over here. So major types I've been discussed already, that is psychogenic erectile dysfunction and organic erectile dysfunction. Psychogenics vary from up to 50% of the patients can have a psychogenic element as a cause of erectile dysfunction, and the rest of the patient can have an organic cause like vascular, neurological. I've discussed already. Some of the patients have a both disorders like organic as well as psychological. So, there are several clinical clues we're actually able to differentiate between psychogenic versus the organic one, especially the onset and non-sustained erections, depression, and evidence of nocturnal erection, basically early morning or nocturnal erection, is another important aspect of the history. And that would give you a clinical clue what is the cause of erectile dysfunction, whether it's psychogenic or organic cause. So let's discuss about how to diagnose and evaluate erectile dysfunction. I would be going from history, important history aspects of the history, then examination, then investigation, and followed by the management plan. Overview of history, basically, most of the patients usually report themselves, so you tend to ask them about the erectile dysfunction. Common causes, identify the risk factors, especially the reversible aspects of ED, and psychological aspects you need to take in a detailed history, followed by examination in the lab test. The sexual history is very, very important, especially when you are taking a history of erectile dysfunction. Mardana kamzori, especially in various parts of our society, most of the males tend to feel shame asking this or telling the doctor about ED. But a kamzori word of any patient who asks about a kamzori, with a kamzori hai, you tend to ask about sexual history of the patient. And sometimes that helps really. Important history, you need to differentiate between a psychogenic and organic cause. A psychogenic cause is suggested by certain onset of ED and presence of ED under certain circumstances, but complete erection at other times. That's a hugely important aspect of psychogenic history. While an organic cause, gradual deterioration of erectile quality over months of years with observation will be just an organic cause. The desired mostly is more or less good, but patient is unable to attain erection. You need to ask about sexual desire, ejaculatory functions, control orgasm dysfunctions, and pain, and especially the partner issues, menopause, a thorough history, followed by a psychological evaluation, and need to ask the medical history, especially the organic history like presence of hypertension, diabetes, peripheral vascular disease, smoking, and surgical history like any trauma in the past or drugs, any drugs patient taking which can be a cause of PD. At the end, a validated questionnaire has been made. That is the International Index of Erectile Function. That can be used to classify, quantify basically the degree of erectile dysfunction the patient has. Dr. Wahab would discuss the psychological aspects of erectile dysfunction, lack of sexual knowledge, poor sexual experiences, relationship problems, very common cause, religious beliefs, cultural beliefs, restrictive upbringing is another aspect that we have seen over here in our society, unclear sexual or gender performance, and previous sexual abuse. That is another aspect of erectile dysfunction, especially in young males, physical or mental health problems, other sexual problems, and the drugs. We need not to forget about the drugs, which can be an important cause of PD. This is the list of drugs. List of drugs I'm not going to highlight, but then important drugs you need to remember, especially the spironolactone and beta blockers, and a lot of antidepressant and antipsychotic medication. Cimetidine was once very famous drug for heartburns and dyspepsia. We no longer use it because of the side effects of fire. Several hormones are also implicated. We all know as a practicing endocrinologist, a lot of hormones actually also implicated in treatment. So this is a questionnaire, International Index of Erectile Function questionnaire comprising of 5 questions. You hand it over to the patient and the patient can able to answer and then classify the degree of the erectile function the patient has. This is the Urdu version, and thanks to Dr. Asif, one of my colleagues who published this questionnaire in the Journal of Sexual Medicine in 2012. That was good work, especially in Urdu. You can print it out and hand over to the patient, and the patient can able to answer and then classify degree of erectile function the patient has. The patient having a score around 5 to 10 is classified as a severe erectile dysfunction. A patient having a score more than 20 or 21 is classified as a NOID. That's a very validated and well-published article. Once a sufficient history is attained and you're able to diagnose the shade between psychological aspect versus the organic cause of ED, you go for examination. Especially you look for the development of secondary sexual correctors, and then a general examination like cardiovascular examination, abdominal and neurological examination in terms if the patient has neurological problems, and followed by examination of external genitalia, especially to look for the penile disorders, especially cirrhosis, urinary disease, and then testes examination, especially the volume, consistency. At the end is the digital rectal examination if needed. Followed by labs. You need not to do all labs in all such patients, but a good history would guide you regarding the important labs you need to do, especially if you are suspecting an organic cause. Since we all know that diabetes is very, very common in our society, so getting a fasting glucose and HbA1c or fasting lipid profile would guide you regarding the organic cause of the erectile dysfunction, and then specialized investigation including hormonal profile, including a morning testosterone. You need to keep in mind that the bonding levels are important rather than aging. And if the testosterone comes low, you can order FSH, prolactin, and especially we order SHBG, sex hormone binding globulin, in those patients who are obese and who present with a marginally low testosterone, marginally low. You can calculate the free testosterone or bioavailable testosterone by getting SHBG. Or some of our labs actually do free androgen index, and that is very useful, especially if you are suspecting this testosterone the patient has is falsely low. Other tests which can be ordered like thyroid test and PSA, that is prostate specific antigen, especially if you are thinking that the patient should be given testosterone replacement. Uh, Hypogonadism, especially if you are able to diagnose hypogonadism, low testosterone, need to find out the cause of hypogonadism, especially the primary or the secondary one. And this is the most important. If you are able to diagnose erectile dysfunction as a hypogonadism as a cause of erectile dysfunction, this is the treatable cause of erectile dysfunction. You replace the testosterone, you give the testosterone from outside, and the patient improves. There are specialized investigation. I'm not going to detail about these investigations. We usually rarely order these one, but sometimes they do are necessary. We usually take help from our urology colleagues. You can order different types of tests, like especially color Doppler ultrasounds to assess the vascular integrity. Especially young adults who have suspicion of peripheral vascular disease or vasculitis phenomena, cardiovascular abnormalities, before considering them for a surgical intervention. This test is a color Doppler ultrasound that has been available in various centers in our hospitals. Usually involves injection of a prostaglandin, and a vascular response has been to be observed between 2 to 10 minutes. And you can see the normal values that you there. And this test is useful to assess the arterial integrity and assess the veno-occlusive mechanism. If the patient has a venous leak, and that would help to decide the management of the EDS. The side effects usually need to look for priapism over here as well, because this injection can cause priapism. So just last few slides before I close my presentation. Overview. Treatment. Once you're able to diagnose whether this is a psychogenic cause or an organic cause, or both can be a cause, then you move towards treatment. You got the test. If the treatable causes are found, treat the ED. Like the overview is basically the lifestyle modification. If the organic cause is obvious, lifestyle modification is very, very important aspect of erectile dysfunction. And then curable causes of erectile dysfunction. And then the therapy itself, like medical therapy. Medical therapy can be divided into 3 parts, like the first line therapy, most commonly used, easily used, followed by second line and third line therapy, usually with the help of our urology colleagues. Lifestyle modification, especially if the patient is heavy smoker, we tend to ask the patient to stop smoking, try to do a regular exercise, maintain ideal body weight. If the patient is taking a regular alcohol, tend to counsel him to stop alcohol, that can be cause of erectile dysfunction as well. And a lot of our patients who present with a very poorly controlled diabetes and uncontrolled hypertension, you need to optimize the treatment so that diabetes control gets improved, hypertension gets improved. We have been seeing, although I'm not brought any slides over there, that once you control diabetes, erectile dysfunction does improve. But especially in those patients who have a short duration of diabetes, but the patients who have a longer duration of diabetes, who have established complication of diabetes, you need assisted drug therapy along with the improved control of diabetes. Sometimes a change of medication can improve ED as well, especially if the patient is taking beta blockers. You switch the beta blockers to those beta blockers to not to cause erectile dysfunction. Like if the patient is taking atenolol, you can shift the patient on nebivolol. That has less evidence to cause erectile dysfunction. But after taking a description from a cardiologist, who are actually these cardiac patients usually are on beta blockers. Treatment of curable causes we tend to do in our clinics almost daily. There is a hormonal cause of erectile dysfunction, easily treatable with the help of testosterone supplements, injectable or gel testosterone is available. If the patient has a post-traumatic cause, role of urological surgery is over here, and has sometimes gives very good results. And with the help of our psychiatric colleagues, psychological aspects, especially the treatment of anxiety and depression, is very, very helpful in treating this erectile dysfunction. And just the last slide, and especially when you are requiring medical treatment, you go for a oral treatment first line therapy. Unfortunately, we do not have a licensed drugs available, but we have been using these drugs for a very long time, and they are all available in the market with a different name, especially phosphodiesterase E inhibitors. Viagra, Cialis, Vitra, and various Indian brands are available in the market. Although you can get it from, they are not licensed by the government, but you can get it from most of the pharmacies over here. Topical form of the therapy, although less useful, was once tried. The oral drugs are very effective, but not affecting every patient. You need to keep in mind that uh, counterfeit medicines are very commonly available there, and patients find quite difficult to get the right original drug. Second line therapy is sometimes used by our urology colleagues, especially vacuum assisted devices and injections, especially the intravenous injection. And third line rarely been used, but sometimes very helpful in those patients who are unable to maintain erection, penile prostate. So thank you so much. And before I conclude, it is not uncommon. It's very common in our society, and a thorough history and a good investigation while to tend to save the cost, investigation cost, as well as tend to reduce anxiety and stress of the patient. They have good treatment options available, and usually a thorough history is essential to take a good treatment and history, treatment of the patient. Thank you so much.